for many reasons, inclusivity has become a popular term, but I truly mean it in this sense that the more our strength is our membership. So the more members we can get involved in our various activities for oversight, for ideas, for participation, for engagement, for carrying through with plans, the better. And I think if all our society members feel like they belong to the society, that we're advocating for our patients and for how we can best deliver care to our patients, will be a much stronger and vibrant society. I think many of the issues we face in treating patients with vascular disease as vascular surgeons are global in nature. And so I'm really trying to make a huge effort to interact with all of Europe, the rest of the globe, and try to figure out how to help vascular surgeons and our patients throughout the world. And I've been fortunate enough. I've worked as an associate editor on the European Journal of Endovascular Surgery, but we've tried really hard to reach out to all members that might benefit throughout the globe. And I think we can do a lot. There are many parts of the world that don't have the resources that Europe and North America does. So how can we help those countries, primarily parts of Asia, Africa, and Latin America, improve the care for their patients, but with more cost effectiveness and less of the uh, exuberance and expense that we might have in more wealthy countries. I am fairly active on social media, particularly Twitter. And when I first heard about Twitter, I thought it was silly. And then I decided to just get an account to kind of see what would happen with it and just follow different people. So I started following pretty much anyone that had any expertise in vascular disease. And I have a few other things I'm interested in, such as evolutionary biology, and I like to read, so I follow authors and med Twitter for book readers and so forth. And it came obvious after a while that you could really expand your influence and reach. But what makes vascular surgeons different? How do we differ from other specialists that also may provide aspects of care for our patients? So, for example, interventional radiology, cardiology, vascular medicine. There's some overlap in what we do. And what we decided that really defined vascular surgeons as we provide comprehensive longitudinal care. So that means that you evaluate patients with vascular disease with the history, physical, and appropriate diagnostic testing. Many of the patients we see don't need interventions, and that's a huge message I try to bring to my patients. Most of the patients with PAD and claudication actually just need risk factor modification and exercise therapy, but some progress and need intervention. And vascular surgeons are the only specialty that's specifically trained not only in endovascular therapy, but also open surgical reconstruction. So the two hashtags we came up with, one was comprehensive vascular care, which we try to use when we're branding that our specialty. The other concept was that surgery is only part of our story. So we created a specialty, a video. And the idea was we don't want to not define ourselves as surgeons because we are surgeons. We do open surgery, but we also do many other things besides surgery. So that actually is reverberated with lots of our members. Surgery is only part of our story. Everywhere I've practiced, from my fellowship in the Air Force, then subsequently to Arizona to Houston, the diabetic foot has been neglected, and it's a global problem. So diabetes is increasing in prevalence throughout the world, and in most places, the care for that problem is fragmented. And many of these patients require not just foot care, but have vascular disease. So we developed a model when I was in Arizona called the Southern Arizona Limb Salvage Alliance, and we basically aligned podiatry and vascular surgery as part of the same group and had outreach clinics and came up with an algorithm for care where all patients were seen by both specialties, and plans were executed based on assessment of the severity of the wound, the infection, and ischemia. And since I came to Houston, we have the same issue here. Houston is it's the fourth largest city in the country. It's an international community, and we have many problems with diabetic foot issues among our underrepresented minorities, particularly Hispanics and Black Americans. So I've tried really hard to figure out how to apply that model on a regional basis and hopefully through linking different regional care centers on a national basis. So I guess the message is how can we make patients aware of what causes diabetic foot ulcerations, how they can prevent them, and then how to get them access to the best possible streamlined multidisciplinary care when they're unfortunate enough to get an ulcer. There's a lot of new things on the horizon. There's wearable technology to monitor for temperature and pressure, and but we always have discussions on this issue. And to me, the main research priority is how to practice what we already preach. So we already have many algorithms of care that are excellent. We know that multidisciplinary care is better. So the question is, how do you do this regionally? So the SVS has a program called VISTA, Vision and Service to Others, and we've now funded three programs, one actually in Houston in Harris Health, and two in rural areas to try to figure out how to provide care to patients who have difficulty accessing care, either because they are too poor, because they're in a remote site, or their job precludes them from being able to attend to care. So this service will probably be expanded to other areas of vascular care, but the one that we thought was the most meaningful at the present was amputation prevention and foot ulcer care, because that in almost all countries there shows clear disparities there based on economic disparities, social disparities, and racial disparities. So we think we can help with that by organizing regional focus groups to develop methods to work with this.